Chapter 14, Assessment. We're going to start with the principles of assessment. So the very first thing is history. So your patient history has two different components, which is going to be the history of present illness. So what's going on right now? What made them call 911? Why did they decide to go to the hospital today? What exactly is going on right now? And then any kind of past medical history. So we're going to ask questions about things related to what's going on, and then some of the big ones like, have you ever had a stroke or a heart attack or things like that. History taking. So we're going to start always by asking the patient. There are going to be situations where the patient's not going to be able to answer you or may not know their history. Situations such as the wife is the one who primarily takes care of her husband's medications and doctor's appointments, children. Maybe the patient has dementia, something like that. Or if the patient's unresponsive. If they're unresponsive, we're going to try family members. If there's no family members, we'll try bystanders. Then if all that fails, we're going to look at the medications that are there and just observe the patient. Try to ask open-ended questions. Things like, what kind of medical history do you have? Instead of things like, have you had a heart attack? Or have you had this? Or have you had that? Unless they're having trouble answering those questions, then by all means go ahead and get specific. So OPQRST is a mnemonic that'll help you kind of remember the questions you need to ask about what's going on right this second. Starts with onset. So how long ago did this start? Did you start having chest pain 10 minutes ago, 30 minutes ago? When did this start? Provocation is your next one. So provocation is, does anything make it better or worse? That's going to be followed by quality. So can you describe what you're feeling? R is radiation. So does the pain go anywhere? Does it stay in the center of your chest? S is severity. So this is going to be on a scale of 1 to 10, with 1 being nothing and 10 being the worst you ever felt. What is your pain at right now? And T is timing. So is your pain constant or does it come and go? Next comes sample. So another mnemonic that we can use to help make sure we get all the information we need about the current patient. So S is for signs or symptoms. And I know we've talked about this one already, but just so you have it. Signs, of course, are going to be what I can see. So the patient has hives. I can see that their arm is bleeding. Symptoms are what they describe. So I'm having chest pain, things like that. We're going to ask about allergies. Are they allergic to anything? Whether it's medication or food, and is there any chance they've been exposed to that? Any medication. So not only what they are taking or what they've been prescribed, but we also want to know, are you taking what you've been prescribed? Any kind of pertinent past medical history. So any comorbidities like hypertension, diabetes, high cholesterol, anything like that. And then in addition, has this ever happened before? And if it has, what was it then? Last oral intakes is specifically if you had any food, drink, or drugs, and then what were you doing when all this started. So if we're going for kiddos, anybody preschooler and up, let's try to talk to them first. Remember, with preschoolers, we're going to use really simple language like, does your tummy hurt, or can you tell me where it hurts? School-age children are going to be able to describe what they're feeling a little bit better, hopefully. Try to start at their feet and work your way up. This is to build trusts. And then include parents, teachers, caregivers, whoever's around to help you with your interview. All right, going into physical exam. So some of your techniques. We're going to perform this examination before, during, and after patient history. And there's 3 primary techniques. Observe. So just what do you see? Do they look like they're in distress? Do they look like they're hurting? Do they look like they're having trouble breathing? What do you see? Next is going to be auscultate. We're going to listen to lung sounds. What do we hear? And then finally is going to be palpate. We got to touch our patients. For kiddos, remember to approach frightened children slowly. Try to avoid anything super invasive, checking blood sugars, getting into areas that hurt until the end. Go toes to head. Explain everything you're using before you use it. This is going to listen to your heart. This is going to do this. This is going to do that. Don't lie. So if you're going to check a blood sugar, it's going to hurt. Don't tell them it's not. Make sure they know it's going to hurt so that they don't see you as someone who's lying. And then try to do privacy, if at all possible. If they want to be away from their parents or their caretaker, try to respect that. All right, body system exams. So we're going to go through each body system and talk a little bit about some of the options and exams for that. So a neurological exam. We'll start with, of course, the simplest one, mental status. Are they alert and oriented? Are they able to tell you what day it is, where they are, what's going on, or are they confused? This is going to be a sign of dysfunction in the body. If the brain's not getting blood, glucose, oxygen, then it's going to start to present as altered mental status. So try to get a history. What is their normal or their baseline mental status? Are they normally a little confused? Do they have dementia? Are they just a little off sometimes, and that's normal for them? And that's going to be what we consider the baseline. Try to get a history of neurological complaints. If they ever had a stroke before, if they had Parkinson's, do they have MS, things like that. Note any patterns in speech. So the best thing to ask for that is to ask the caretakers, hey, is this the patient's normal speech pattern, right? So we aren't going to necessarily know what may be normal for someone versus what's not. What I may hear as a normal speech pattern may for that patient be completely wrong. So the best thing to do is ask before we leave, hey, is this normal for them? So for the physical exam, we're going to do a stroke scale. So we're going to talk about this a little bit and demonstrate it in class. But the stroke scale that we use generally in EMS is the Cincinnati stroke scale. We also use something called a fast stroke scale or a van stroke scale, but we'll talk about that when we get into neurology. The stroke scale is going to do things like make sure the grip is even, that the arms stay up when a patient holds them up, and that their face is equal and their speech is normal. Do peripheral sensation and movement. So, rub both hands and ask them if it feels the same. Palpate the spine, especially if you've got any concerns of trauma. We're going to check extremity strength. Make sure our pupils are equal and reactive, which is called PEARL. Pupils equal, round, reactive to light. Try to figure out if the patient can walk. Can they normally walk? Is their gait normal? Are they unbalanced? Are they dragging a leg? Or is it hard for them to get up? Are they dizzy? Have they had a seizure? Any kind of vision problems? And again, pupils. Cardiovascular disease. So this, of course, has to do with the heart, the blood vessels, and then a cardiac patient and patients who are in shock or with a vascular problem, because it all goes back to the heart. And then we need to know their history. This is things like existing conditions and medications, and then signs and symptoms of what's going on. And then if they're having chest pain, we need them to describe it. Is it sharp? Is it pressure? Does it, is it worse when you take a breath? And that's going to be our kind of specific characteristics of their discomfort, and it'll lead us towards what's going on. So for your physical exam, we're going to look for signs and conditions. It may be severe. You're going to get a pulse. Is it strong? Is it weak? Is it regular? Is it irregular? Get a blood pressure. Note pulse pressure, which is the difference between the two. So are they really close together or really far apart? Look for JVD. So JVD stands for jugular vein distension, and it's that jugular vein, external jugular in your neck. And the vein will actually get so puffed up and full that you'll see blood back up. Has to do with increased pressure in the chest. And we'll talk about it some both in trauma and medical. Palpate the chest. Of course, do a 12 lead. So the rule of thumb that you're going to hear in this class is nose to navel. So if they're having pain anywhere from their nose to the belly button, they get a 12 lead. And then do they have any pedal edema? So when we talk blood flow of the heart, we talked about how if the right side of the heart starts to fail, that blood will start to back up, back into the vascular system, and it'll go back to the feet because that's where it's having the hardest time pumping that extra fluid. Respiratory systems are anything to do with our lungs. This, of course, is our most important assessment because if they're breathing, we can do a whole lot more, where if they're not, we're going to have to intervene quickly. Try to get a history. So do they have any existing respiratory conditions? Do they have COPD? Do they have asthma? Have they had this before? A recent diagnosis with pneumonia? Try to get all of that. Figure out if they've taken any medications and if they're taking them like they're prescribed. So are they prescribed a rescue inhaler? Did they take it? Do they take a home nebulizer treatment? Do they do it maybe proactively? So they take it 2 or 3 times a day? Take a look at that and see if you can figure it out. Determine signs and symptoms of the illness match the previous episode. So have you had this before? And is this similar to your last asthma attack? And is it worse or better than that? So physical examination, level of respiratory distress. Do we have nasal flaring? Do we have intercostal movement? Are we having trouble with just basic in and out ventilatory status? Do we have a lot of chest wall movement? Is it up and down and we can very dramatically see the chest wall, or are we barely moving at all? Of course, listen to lung sounds. So as you know, I push and push and push that lung sounds should happen in the ABCs. In your primary assessment, we listen to lung sounds. Because if there is something that needs to be intervened on quickly, stridor, no breathing, attention pneumo, you need to get the appropriate people started towards you as soon as possible. Use your pulse ox. I agree wholeheartedly to utilize your pulse ox as much as possible when needed. However, remember too, it is just a machine. So if you have a patient who's in obvious distress, they're tripoding, they're nasal flaring, you can tell they're having trouble breathing, and the pulse ox says 98%, put them on oxygen. It doesn't matter what the machine says if your patient needs it. Look for edema. So do we have that pedal edema we just talked about? Do we have edema in the sacrum? Do we have edema in the genitalia? Look for edema. Do they have a fever? Do they have the head chills? Do they have any retractions? Do they have a cough? If they do, is it productive? Or is it a dry cough? If it is productive, is it bright green sputum? Is it clear sputum? Is it yellow sputum? Is there blood in the sputum? Any nasal drainage? Or are they congested? All right, next is going to be your GI tract. So, when we talk GI, we're looking for what's gone in and what's come out. So, have they had a recent bowel movement? Have they had a normal amount of urine? And then what does it look like when it comes out? Did they have diarrhea? Is there blood in it? Things like that. We want a history. Do they have pain or discomfort? When's the last time they had something to eat or drink? Do they have any history of GI issues? Does the patient have diverticulitis? Have they had a GI bleed before? Do they have a history of just being nauseous? Things like that. Are they vomiting at all? Again, when was their last bowel movement? So physically, we are going to look at their position. Are they crunched over up in a little ball and it looks like they're in a whole lot of stress and distress? Or do they, are they just kind of relaxing on the chair? Assess the abdomen. So we're going to palpate all 4 quadrants of the abdomen. Look for other parts of the genitalia systems, the mouth, things like that. If there's vomit available or feces, look to see if there's blood. Reproductive system. So, when we talk reproductive, it can range anywhere from woman's gone into active labor to an infection in their uterus. Anything in between, or an STD. Any female of childbearing age with abdominal pain, weakness, or fever should be assessed for the reproductive system. So we need to ask these questions. When was your last menstrual cycle? Is there a chance of you being pregnant? Even if they are on birth control, there is still a chance. It is not 100% accurate. Are they having any pain? If they are, where is it? What kind of pain? How long ago did it start? What does it feel like? All those same OPQST questions. Is there any discharge? So are you, in the middle of your menstrual cycle? Is there clear discharge, colored discharge? Is there a smell with it? Things like that. Endocrine system. Most common endocrine disorder that we're going to deal with in the field is diabetes. Some of the other ones that fall under this are going to be things like hypo or hyperthyroidism, Addison's disease, stuff like that. However, the one that we see the majority in the field is diabetes. So get a good history. Do they have any diabetes or thyroid history? Do they take current medications, and whether they're taking it properly? So unfortunately, a lot of diabetics are not fantastic at taking medication like they should. And so we run into issues of, oh yeah, I have insulin, but I haven't taken it, or I didn't check my blood sugar first, and that's why my sugar's now 34. Have they eaten or exerted energy at the same level? So a diabetic who normally can maintain their sugar and is well within the normal ranges on a regular basis with medication, if today all of a sudden they decide, you know what, I'm going to go for a 6-mile hike, and they didn't change the amount of food that they took in or change the amount of insulin they took, their sugar is going to plummet because they don't have the carb load to support that sudden extra onset of exercise. Same thing if patients get sick. Their appetite goes down, they don't really want to eat, and then their blood sugar will end up going down as well. And then do they have they checked their own sugar recently? Or do they use an app or an insulin pump? Integumentary. So integumentary is a really fancy way of saying your skin. So it's often gone with other complaints. So like what you see here is urticaria or hives. So this patient is probably having an allergic reaction. So the complaint is going to be the body's immune response system to that allergic reaction. However, the integumentary system is involved. It is your largest organ in your body, which means it takes a lot of your blood flow to stay perfused. So ask for a history, and have they had any recent surgeries, any wounds, and any kind of skin conditions like eczema or something like that. So, do they have a rash? Do they have hives? Edema? What color is the skin? Is it pink? Is it pale? What color is it? Do they have a temperature? A fever? All right, musculoskeletal. So, of course, this has to do with your skeletal system. Medical diseases in this system are pretty rare, but they do happen. Most musculoskeletal exams will be performed as part of trauma. So, we're looking to see if they broke something. Ask for history, if they've had any prior injuries, whether they take any blood-thinning medication, and any kind of underlying diseases or conditions that make fractures more common. So, fractures that come secondary to a disease, such as osteoporosis or something like that, are called pathological fractures. And all that means is that it wasn't because, the patient hit their arm that the arm broke. It was because that bone was already weakened from osteoporosis that caused the fracture. A normal person wouldn't have fractured their arm that way. And then history to determine if a medical problem could have caused the injury. So, do a physical exam. Check for signs of injuries or deformities. Palpate areas of the suspected injury. Compare sides for symmetry. So, do both sides look the same length? Do they feel the same? Do they look the same? Be alert for crepitus. So, crepitation means that two bones are rubbing on each other. Assess the patient head to toe if there are multiple fractures or if they're unresponsive. So, the reason we say if there are multiple injuries to assess the patient toe to toe is because it is easy for what is called a distracting injury. So, let's say the patient broke their hip. It would make complete sense for them to maybe not feel that they also broke their finger. So, it's our responsibility to do that head to toe and make sure we find all of the injuries. And then range of motion. So can they lift it like they normally could? Can they bend it like they used to be able to? All of that matters. All right, let's talk immune systems. So your body does this really good job of taking care of you. If something foreign enters the body, it will send something to attack it. So immune system-wise, allergic reactions are most relevant for EMS. We don't see a ton of true anaphylactic reactions, but sometimes we do. But we do see a lot of allergic reactions. So an allergic reaction is going to be a reaction to some kind of allergen. And when it gets severe and when we really have to intervene, it's an anaphylactic reaction. So ask them if they have a history of allergen and then have they been exposed to it. And what do their reactions normally look like? So the more exposures a patient has to an allergen, the more severe the reaction is going to be. So, like the first time they got stung, they might have had a little bit of trouble breathing and been nauseous. The second time, they might have a lot more trouble breathing and start throwing up. And then the third time, they may actually stop breathing. So, we need to make sure that we have an idea of how bad their previous ones have been and what we think we're looking at for this one. And then, do they have a history of asthma? Just because that can make the respiratory symptoms worse. Then if they're itchy or they've thrown up, do they have a rash? And do they have any medications for this allergic reaction? So does your patient already have epinephrine or something like that available to them and have they taken it? So look for a physical exam. We're going to look to see if they, one, where did they get in contact with the allergen? So if it is through the integumentary system somewhere, we're going to look at that spot. If it's something such as a bee where the stinger is still inside the patient, we're going to take the time to scrape it out so that it stops injecting poison for the patient, stops injecting its venom. And inspect the patient for hives or a rash. So on this side here, here, and here are just two different kinds of rashes. So the little bumps over here, just these little tiny bumps, those are a rash. And then these bigger one are hives. Inspect the face, lips, and mouth. So it's called angioedema. We want to see if the patient is swelling on their airway because that is going to be such a big thing that we need to intervene with quickly. Listen to them when they talk. Is their voice raspy? Does it sound like you can't really hear it? What does it seem like? Listen to lungs. Again, we listen in our primary assessment. That is what you guys have been taught to do. However, you also need to probably reassess in your secondary, especially in a situation like this. If the patient has had a reaction to something that is known, that they may have an anaphylactic reaction to, we are going to reassess those lung sounds frequently. So when we reassess vital signs, we're going to take those lung sounds again, just to make sure that the patient hasn't progressed to a respiratory issue. All right, psychological system. This is our last one that we're going to look at. So let's talk history. Do they have a psychological history? Have they had some problem like this before? Do they take medications for it? Are they seeing a counselor? Do they have things like PTSD, schizophrenia? Do they have depression, anxiety, bipolar disease? Things like that, so that we have some idea of kind of where we're starting and what we're starting with. Are they been diagnosed with it? And then also, are they seeking for or currently under treatment for it? Just like any other disease, psychological disorders don't always get treatment like they should. Are they compliant with that medication? And is it acute or chronic? So have they felt this way for a long time, or is this a new onset? So do they have a history of substance abuse? So are we in withdrawals? Have they taken something today? Have they taken something in the past? Unfortunately, with some of the psychological disorders out there, especially things like paranoid schizophrenia, bipolar, sometimes patients will, before ever being diagnosed, seek self-medication. So they don't know what's going on with them, but they know that if they take heroin or cocaine or things like that, they feel better. And so they may self-medicate prior to ever being diagnosed, which is where the substance abuse rates go through the roof if the patient is a psych patient. Do they have any suicidal ideation? Have they attempted? So ideation just means that they feel like they want to kill themselves. So suicidal ideation. An attempt means they have actually physically done something. So they have hung themselves, they've attempted to hang themselves, they have taken medication, they have done something that would cause so much self-harm to kill themselves. And then kind of in between the two is a plan. So do you have the ideation or thoughts about it? And have they come up with a way they're going to do it? So while they may not have actually attempted it yet, maybe they have thought it out and they know that they're going to use their grandfather's gun or they're going to overdose in their psych medications, whatever it may be. Those are important questions because once we figure that out, it will help determine if the patient needs to be seen by psych in the first place. It also helps so we can make sure it gets passed on so it doesn't get overlooked. If a patient is having suicidal ideations, we want to intervene before it goes any further. Also, homicidal ideation. So some of your patients may have suicidal and homicidal ideations. If they're having homicidal ideations, have they attempted to kill someone, or do they have a plan on it, just like we would with suicidal? Precipitating factors. So is your patient having a panic attack because you just told them that, you were unable to save their daughter or their grandfather? Are they under a significant amount of stress at home? Was it a domestic violence situation? Or have they ran out of money to get their medication, and so they're unable to continue to take it? Unfortunately, with some of the psychological disorders out there, patients aren't always able to hold steady jobs because of, difficulty getting to work, difficulty with self-care. And so if they're unable to do that, they may not be able to hold health insurance, and they may not be able to continue on the medications that do help them. All right, so let's go into what we do with all this information. So now we've done an assessment, we've done our primary, we fixed the life threats, we've done a secondary, we have an idea now of what's going on. So what do we do with it? So, diagnosis is a label for a condition. It's based on the history, physical exam, and vital signs, which we do all of that. It involves both physical and intellectual activity. You know what I mean. Activity within your brain. Clinicians have different levels of training, experience, time, technology, and other resources. So technologies may also vary among the different types of clinicians. So quickly rule in or rule out immediate threats. We did that already. We do that in primary. We say, airway's not working, we got to fix it. Breathing's not working, we got to fix it. Gather information on the patient, the family, friends. Try to get as much of that information together as you can. Perform a physical exam. So we talked about that. When it comes to a medical patient, you can do what's called a focused physical exam. So if my patient is having neurological symptoms, we can do a neurological exam. Now, the only caveat to that I will add is your patient still needs to have lung sounds done no matter what, because airway still matters, no matter what else is going on. And then if your patient is altered at all, we need to just go ahead and do a head-to-toe assessment to make sure we don't miss anything. Focus on ruling in or out the worst-case scenarios. So for a chest pain, we're going to rule out or rule in heart attack. For a neurological complaint, we're going to rule in, rule out stroke. We're going to go for the big ones first, because those are going to determine things like transport decision, destination, do we need ALS, what interventions are we going to do? That's going to be the beginning, and then we'll kind of go from there. So some red flags may suggest a serious problem. You may also be responsible for multiple patients, so just be aware of that. So what do we do with it? It has to be efficient. We can't stay on scene for 30 minutes trying to do a detailed assessment. We work in a super uncontrolled environment with a limited tool and skill set and a narrow educational focus. Consider most serious conditions associated with the patient, rule them in or out, and then create your differential off of that. It doesn't have to be perfect. When we talk differential diagnosis, we're talking, hey, I think my chest pain patient is having cardiac chest pain. That's good enough. You, at your level as an EMT, don't need to make a decision on if they're having a heart attack or not. Cardiac chest pain is enough for you to recognize that it's above something you're able to handle and they need to go to the hospital. And that's enough. That's all you need to really get to. So experienced providers learn some shortcuts. I had some shortcuts. They do pattern recognition that narrows down some of the possibilities. I will preface that with, you cannot use the shortcuts until you learn your foundation. I had someone who used to precept me many years ago, and one of the things that she would say to new providers is that you can't hang curtains on a house until you build the foundation and the walls and put the windows in for those curtains. So when you try to skip the steps to get to the shortcuts, you're not putting in your foundation, you're not building your walls, you're not framing the house. All you're doing is going for the curtains, and there's nothing to hang them on yet. So someone who's been in it for a really long time, like I have, and some of the providers you ride with, they may skip a step or two because they recognize what they're seeing in front of them. You know, I've had patients that present like this. Most of the time it's XYZ. Let me try to fix and intervene for that. You guys aren't there yet, and that's okay. So just be careful of that and make sure that we're not doing something that causes us to miss things because you come out of the class and you want to try to be a provider and you're brand new and you're trying to do things that 20-year providers are doing. Learn to love ambiguity and understand the limitations of technology and people. Realize that not one strategy will work for everyone or everything. So every patient we see is going to be different. We can teach you a generalized guideline. If you have a cardiac chest pain patient, you are going to do a 12 lead. You're going to give them aspirin. You're going to assess their vital signs every 5 minutes. You're going to transport them to an appropriate facility, call for ALS, give them oxygen if needed, but make sure our stats don't go over 99. And you may give nitro depending on what their blood pressure is. I can give you those generalized things. But depending on the patient, maybe we can't give nitro because their blood pressure is too low. Maybe you can't get ALS because they're out on a call. Maybe the closest appropriate facility is on diversion and you have to go somewhere else. So every call, every patient are going to present differently, are going to present just a little off. And so while we give you guidelines, you're going to have to function within those. That comes from that solid foundation of knowledge that I talked about. All right, so let's talk secondary assessment. So the components of a secondary assessment are falling under 3 different categories of patients. Your medical, your trauma, and your unknown. So for a physical exam, then we're going to do patient history, history of present and past medical history, and of course vital signs. So, secondary assessment of a medical patient. This is going to vary dependent on their ability to communicate. So a responsive medical patient, we're going to obtain their history, perform a physical exam focused on what they're saying is hurting. My stomach hurts. Okay, I'm going to palpate their abdomen. I'm going to be able to ask questions based pertinently on what they're saying hurts. If you're saying your stomach hurts, I'm going to say, okay, when's the last time you had a bowel movement? Do you still have your appendix? Have you ever had any gallbladder problems? Depending on where the pain is, things like that. Obtain that baseline set of vitals. We do that for everybody. Administer any interventions that's appropriate. So that same patient that's having abdominal pain, if they're nauseous, You guys could give ODT, or what's called, it's basically oral disintegrating tablet. So it's a tab that goes under their tongue for nausea, and then transport. And then get their history and obtain from the patient first, then family if they're not able to do it. So we are going to tailor our physical exam to the specific complaint if the patient can tell us. So important information can be gained by tailoring a history to a patient's chief complaint. Ask questions that are pertinent to that chief complaint. So like I said, with that nausea and abdominal patient, when's the last time you ate? What if you had to eat or drink today at all? This has been going on for a little bit or a long time. Do the physical exam. Palpate their abdomen. It's usually pretty brief. Try to do what hurts last. And then examine areas based on chief complaint. Get your vital signs. So this is essential to every medical patient. Later assessments of vital signs get compared back to these baselines. In order for there to be a trend, like we talk about in Chapter 13, you've got to have 3 sets of vitals. But baseline vitals are what start us towards everything else. Take a manual blood pressure. The reality of those really nifty little automated machines that we have is they don't always work. They're based on the ability of the patient to hold still, the ambulance not to be bouncing too much, you to have put the cuff on absolutely properly, and a whole lot of other factors. When's the last time they were calibrated? How undamaged is the equipment? So it is a good rule of thumb that your first blood pressure should come manually. Because if I take a manual blood pressure in the house, and let's say I get 112 over 46, right? I then take my patient out to the ambulance and I reassess them, and the monitor comes back at 210 over 108. I know that either something has significantly and clinically changed in my patient, or the machine is wrong. Because I know that I got mine that was right. So if the machine is incorrect, then we're going to look at things like, is the cuff the right size? Was it placed correctly? Was the patient holding still? Were they flexing? Etc. And we're going to try to fix it. So in your unresponsive medical patient, we're going to begin with a physical exam and a baseline set of vitals, and then try to get history. If you've got enough people, try to get somebody to gather history while you're doing your assessment. And we are going to do a head-to-toe assessment on these patients. They're unable to tell us what's going on. So we have to do a head-to-toe. We have to know that we know what's going on with the patient. Do a rapid physical exam, really similar to what we're going to learn for our trauma patients. Head, neck, chest, abdomen, pelvic, extremities, posterior. We're ruling in and out things. So that rapid physical exam, we're looking for jugular vein distension, medical identification devices. We're looking at the chest for lung sounds. Abdominal, we're looking for distension, firmness or rigidity. The pelvis, we're looking for incontinence. Like, so did they, urinate on themselves? Did they have a bowel movement? Extremities, we're looking for pulse, motor, sensation, and looking again for any medical IDs, and we're going to check our pupils there. So for our vitals, we're going to get pulse, respiration, skin color and temp, pupils, blood pressure, and then anything that's abnormal, we're going to take a note of, and then O2 saturation. The other thing you can add on to here, if it helps you remember, is lung sounds, and then also we'll talk about it, but ETCO2. So ETCO2 is going to be capnography. So what I'm saying is let me see if I can write it out. It's a lowercase t, CO2. And what it is end-tidal carbon dioxide. And it's a little thing that goes in their nose. It goes on the end of the tube if we're ventilating them. It's a really good vital sign, and we'll talk about it. So, ALS. Follow your local protocols, but consider if that paramedic is going to be beneficial to your patient. Some areas, ALS may not be an option. So where I started EMS, we didn't have ALS. You either transported to our little 4-bed ER, or you called a helicopter. Those are our 2 options for ALS. Consider the closest options for your health facilities. So in this area specifically, think about, if I'm going to call for ALS, they're going to have to come from a station, maybe the same station I came out of, maybe another one. Am I going to be able to rendezvous or meet with them en route to this call, en route from this call to the hospital, faster than I'm going to be able to just get to the hospital? The last thing you want to do is wait on scene for a medic or stop in the middle of the road or go the wrong direction from the hospital for ALS. At that point, just transport to ALS, to the hospital. Also, I say the last thing you want to do, but we will caveat that if the patient is in cardiac arrest and ALS is coming, we are going to wait on scene for ALS to get there. Get a history. So question your bystanders if the patient can't answer. What's the patient's name? What happened? Did you see anything else? So did you see, were they dizzy this morning and now they're feeling this way? Did they complain of anything? So if they had a headache, they've been complaining of feeling weak or chest pain. Do they have any known illnesses or problems? And do they take any meds? So trauma patients. We talk trauma. Injuries can range from slight to severe. To determine how serious the injury is, consider the location, the injuries on the patient, their mental status, their airway status, breathing or not breathing, vital signs, the mechanism, the age or pre-existing condition. So a 90-year-old woman who's been shot in the chest versus a 30-year-old woman that's been shot in the chest, well, both are extremely serious. The 90-year-old woman's going to have a much harder time with rehabilitation and long-term outcome if they survive the initial injury. Minor. So if it's minor, focus your assessment on the area that is injured. Determine the chief complaint. Get your history of present illness. So how did it happen? And then just take care of it. So history. Nature of force involved. So did we fall off of this ladder or did we fall off the roof? Direction and strength of force. Was it simply a fall or did something yank you off the ladder or push you off of it? Any protective equipment. So this gentleman has a helmet on. So that's something, right? Actions taken to prevent or minimize the injury. So did they do something to make it better? Assess the areas of pain and injuries resulting from the incident, and then go from there. For a physical exam, areas assessed are going to be based on the complaint or injuries. Mechanism may point to potential injuries as well. So we're going to use those three techniques again: observation, palpation, and auscultation. Absorb for abnormalities and symmetry. So do both sides of the chest move equally? Are both arms the same length? Do they look the same? Color. So do both hands have the same pinky pale color, or there's one purple, one white? Shape. Does it look the same as the other one? Do they move the same? Palpate for abnormalities in shape and temperature. So this is another mnemonic. You don't have to memorize it, but it's a really good one to know. It'll help you remember what you're looking for. We say it DCAT BTLS. So we're going to listen for decreased or absent lung sounds and then DCAT BTLS. So deformities, contusions, abrasions, penetration or puncture, burns, tenderness, laceration, and swelling. That's DCAT BTLS. I will tell you that if you say DCAT BTLS during your testing for your physical exam, your medical or trauma assessment, that your evaluator has the right to say, what does DCAT BTLS mean? And you have to be able to rattle this off. So if you can't say deformities, contusions, abrasions, penetrations, burns, tenderness, laceration, and swelling, don't use that mnemonic. Spinal motion restriction. So, apply a C-collar for any patient where you're taking spinal precautions. And that's what we're going to call it. Complete the primary assessment. Care for life-threatening problems before applying the collar. So we're going to hold manual C-spine in the meantime. Use patient mechanism and condition to determine the need for cervical immobilization. So if they just tripped and fell and nothing hurts and they're feeling okay, cool. If they tripped and fell onto something and it's a super distracting injury, we're going to go ahead and place the C-collar because they may not recognize that their neck hurts because they're so focused on the bar sticking out of their leg or something. Assess the neck prior to placing the collar. It's very difficult to palpate and visualize the neck through the collar. I would say it is impossible to be able to palpate the back of the neck through the collar. Reassure the patient. It is not the most comfortable thing in the world. And you guys will have these placed during trauma assessments. They're uncomfortable. They're not pleasant. Explain why we're doing this to the patient and then reassure them that it will get to the hospital. They'll reassess again. So if we've got a high mechanism, multi-system, or a serious injury, they're considered a high priority. We are going to spinally immobilize these patients. They get a full head to toe. They don't do the spinal motion restriction where it's just a C-collar place. These ones are going to get put on a backboard. Consider ALS if you need it. If it is a multi-system or a high priority patient, I would call for ALS. Perform a rapid trauma assessment. It's a head-to-toe assessment. Consider hidden injuries, so things on the inside we can't see, like seatbelt injuries, airbag injuries, steering wheel injuries. So, for the head, we're going to palpate the cranium, face, ears, eyes, nose, and mouth. We're going to look for blood or clear fluid. Battle signs are serious findings. And battle signs means bruising behind the ears. Rapid assessment of the neck. Look for wounds, tenderness, deformities, jugular vein distension. Is there a stoma or a trach? Is that trachea midline? Apply your C-collar. Size and apply if it's indicated by your protocols. Next, we're going to go to chest. Do they have what's called paradoxal movement? So is one side moving and the other not? Do they have crepitation, or that movement and feeling of bones rubbing on each other? What do the breath, lung sounds sound like? Do the rib cage and chest have to be exposed? You can lift their chest up or their shirt up if you're going to leave their clothes on, but most of the time for a high mechanism patient, we're going to cut their clothes off so we can see everything. For the abdomen, we're going to palpate. We're looking for distension or pulsating mass. If there's a pulsating mass, leave it alone. Don't touch it no more. Gently press down on your quadrants and then move on to your pelvic. You're looking for bleeding, or is the pelvic stable? So you're going to push down on the hips and then in on the hips, and we're looking to see if that hip is stable, if the pelvic girdle is stable. Looking for priapism, which is another name for an erection. Priapism on a male patient who's had a spinal cord injury or who has had a back or neck injury leads the providers to think spinal cord injury. It's not a normal response. Do a rapid assessment of the extremities for wounds or tenderness, where pulse motor sensation or circulation, sensation, and motor function are the same thing. You'll hear PMS or CMS. What we're doing is checking for pulses, seeing if they can squeeze or wiggle their fingers or toes, and then can they feel us touching them. For posterior, we're going to roll the patient up on their side and assess them. So for our head for kiddos, don't apply pressure to the fontanelles. They have not secured together yet. Don't poke it. Collisions can produce head injuries because their heads are so much proportionally bigger than the rest of their body. Nose and ears, look for blood or clear fluids just like we do for adult. Remember with kiddos, though, that any mucus or blood clot can disrupt their breathing a lot easier. For neck, their proportionally larger heads increase their risk of spinal cord injuries in a motor vehicle accident. So they may have it without even a fracture just because of the extra range of motion. Remember, their airway is differently sized as well. For the chest, check for breath sounds, check for symmetry, bruising, paradoxal movement, and retraction, just like with adults. For abdomens, notice if it's rigid or tender. And injuries that impede movement of the diaphragm can compromise breathing. Also, I will add, if we strap the patient to a backboard too firmly and cause them to be unable to move their abdomen up and down for children, they may have a difficult time breathing. Pelvic, we're going to check again for stability, and extremities, the same thing, cab refill and distal pulse. So detailed exam, typically completed en route to the hospital, gathers some additional information and helps determine treatment for the patient. This information assists the emergency department staff as well as us, and performed most often on a trauma patient with a significant injury. Remember to perform this only after you've performed critical interventions. You may never get there, and that's okay. If you're treating a severely injured patient and you're too busy to complete the detailed exam, it is not a failure. It is normal. It is your responsibility to give that patient the best care, which means you may skip the exam completely because all you're able to do is maintain ABCs. Well, if you maintain ABCs until you get to the hospital, that patient is alive, and that's okay. Expose your patient. Nothing bothers me quite as much or as big a pet peeve as being called for ALS to a multi-system super sick trauma patient to get there to find them fully clothed. You cannot see what is going on with them if they have all their clothes still on. Noise and motion may interfere with some procedures, so just be aware of that. Work around the immobilization equipment, and the components for detailed are similar to rapid trauma. They're just more detailed and focused. So if they're not seriously injured, they don't need a full head-to-toe detailed assessment. Keep a high index of suspicion, and when in doubt, just go ahead and perform it, but if it's something minor, it's okay. Be aware of the patient's fear and need for emotional support. They may just need you to tell them they're okay. I'm not finding anything right now. Reassessment. So, we are going to reassess key elements of assessment. Identify changes and trends. Don't skip unless you're doing ABCs. So this identifies our changes. Sometimes they're subtle, sometimes they're obvious, and our trends. And then if there's any deterioration. So what are we going to do? We're going to repeat that primary assessment. Is their airway still open? Are they still breathing? Do they still have strong radial pulses or weak radial pulses? Has any of the bleeding that I stopped rebleeding? Is their mental status the same? Skin color and temp. And we may need to reassess our priorities here. And then we reassess and record vitals and compare them to our baseline. Kiddos. The mental status of an unresponsive child or infant can be checked by shouting, hey, 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 or flicking their feet. That's painful stimuli. Please don't shake the baby. Crying is an expected response from a child with an adequate mental status. If your child that you're taking care of has been involved in a motor vehicle accident or a major trauma, I expect the patient to be crying. They should be. They should be upset. They should be scared. If the patient has been ejected from a vehicle or involved in a motor vehicle accident and they are sitting quietly in their car seat, something is wrong. They should not be functioning that way. So, pertinent, past history, physical exam. Chief complaint may change, especially in regards to severity. Ask about changes in symptoms, especially ones anticipated because of treatments administered. So if I gave the patient a breathing treatment, I'm going to ask them, hey, has that helped at all? Do you feel like your breathing's gotten any better? Repeat your physical exam. Check your intervention. So did the oxygen work? Are we ventilating appropriately? Are we still not bleeding? And then whatever else you may have done. If you place the patient in a splint, so they've broken a bone or something like that, we need to reassess to make sure they still have good PMS below that injury. Because if it starts to swell, the split may actually cause blood flow to get cut off. Things like that are what we're going to look at. We're looking for trending. So a change in the patient's condition over time. Condition as well as length of time will determine how often you reassess. So when to reassess? If they are stable, every 15 minutes. If they are unstable or potentially unstable, 5 minutes. So that is it. If you have any questions, please let me know. I know it's a lot of information and it's kind of hard to understand off a slide. We are going to go over the physical, how to touch, palpate, do all of these things in class. A lot of that will start with your trauma assessment. We'll probably do at least one day before Module 2 test. But just be aware, this is something you can come back and reference as you go forward, that a physical assessment is the most important skill that you do. If you do not have good assessment skills, you will never be able to figure out what is wrong with your patient. And that starts at this level and works its way up. Whether you stay in this field and go on to be a paramedic, or whether you go to nursing or medical school or anything like that, or whether you stay in EMT, assessment is the bread and butter of what we do. Every decision we make, every transport decision, everything we do is based off of the assessment that we do. So it is incredibly important to work on having good quality assessment skills.